Thank you, Professor Grenier. Thank you. I'm going to talk about inspiratory and expiratory CT, but the bulk of my talk is obviously going to be about expiratory CT, because I'm going to assume that for most of us the default setting for performing thoracic CT is in inspiration, and I'm only going to talk about two things. One is the role of expiratory CT in the identification of small airways disease, or air trapping, and the second half of the talk is going to be about the role of expiratory CT in the identification of tracheomalacia. So you've already seen this, but just briefly to revise before we go on to talk about specific small airways diseases. The normal small airways are less than 2 millimeters in diameter, and of course we can't see these terminal bronchioles on high-resolution CT unless they are diseased. And you can consider small airways disease as one of two sorts. If the small airways become filled with an inflammatory exudate, well, we can consider that an exudative bronchiolitis, and on CT we typically see that as a tree and bud pattern, but in a constrictive bronchiolitis, where the wall of the bronchus becomes inflamed and scarred and the lumen becomes obliterated, we see air trapping, or we can see air trapping and a mosaic attenuation pattern. So air trapping, again, just to briefly revise, is defined by the Fleischner Glossary as simply a retention of air distal to an obstruction, and on CT it's characterized by parenchymal areas with a less than normal increase in attenuation on expiration. I simply put that up there to illustrate that the glossary does recognize the importance of performing expiratory CTs for identifying air trapping, but it also goes on to say something which is interesting, which is that comparison between expiratory and inspiratory scans can be helpful. It doesn't say they are always helpful or that it's mandatory, and the reason I say that is because I'm going to show you some examples where you can identify air trapping or small airways disease without resorting to expiratory CT. So, first of all, why should we be performing expiratory CT to identify small airways disease? Well, there are two scenarios where it can be helpful. First of all, where the inspiratory CT is normal, or where the air trapping is very subtle, the air trapping can become much more conspicuous on expiratory CT. And secondly, when we're faced with a mosaic attenuation pattern, it can help us distinguish air trapping from a pulmonary vasculopathy. So here is the first of those scenarios where I'm sure we would all consider the inspiratory scan as essentially normal, but on the expiration, we can see that a number of gas trap lobules become conspicuous. Now, I'm going to come to the question of whether or not this is clinically significant a bit later on in the talk. So, which conditions should we be thinking about when we see air trapping? Well, I'm not going to talk about asthma or COPD, even though this is pivotal to these conditions, and you've already heard about the importance of air trapping in COPD and how you can identify it using quantitative methods. Instead, I'm going to talk about visual identification, and I'm going to concentrate on hypersensitivity pneumonitis and bronchiolitis obliterans, or obliterative bronchiolitis, because it's in these conditions where the recognition of air trapping can be crucial to making the diagnosis, and indeed for the radiologist being the first to make the diagnosis. So you probably all know this. Hypersensitivity pneumonitis, just to recap, is a condition characterized by repeated exposures to a particular antigen. And the reason why radiology is important is because quite often the clinicians are unable to elicit a exposure history. And actually, even when biopsy is performed, histopathology is only conclusive in about 50% of cases. So with that in mind, you can understand how CT becomes absolutely crucial. And the classical features are centrilobular ground glass nodules, confluent ground glass opacification, and a mosaic attenuation pattern. And on expiration, on expiratory CT, you can sometimes see this very classical appearance where you have three densities of lung in this particular slice on the same axial section. Increased density pathological, ground glass opacification, normal density lung, if you like, or normal ground glass opacification, which is been produced as a result of expiration, and low-density lung, which is the air trapping, which remains low density on expiration. However, you don't always need expiratory CT to make the diagnosis of hypersensitivity, that is to say, subacute hypersensitivity pneumonitis. In this particular case, the combination of widespread ground glass centrilobular nodules and just one or two lobular areas of air trapping would be sufficient for you to be very suspicious of the diagnosis based on inspiratory CT alone. Okay, I'm going to move on to the second type of small airways disease condition, bronchiolitis obliterans or obliterative bronchiolitis. And in this condition, history is important because it's rarely idiopathic. If you can find out whether or not the patient has a connective tissue disease, whether or not they've had a relevant drug history, a bone marrow transplantation, that's all very important. It's much harder to identify whether or not they've had previous pneumonia, but if you can get that information, it's useful. And here is an example of fairly severe obliterative bronchiolitis. On the inspiratory scan, you can just about make out the Mosaic attenuation pattern with areas of grey or increased attenuation lung next to areas of reduced attenuation lung. But crucially, on the expiratory CT, it becomes much more conspicuous. And there's a point I want to make here. Not only does the air trap lung remain of low density, but you'll notice that it doesn't reduce in volume. So the normal lung not only becomes of increased density, but you'll notice how it has lost volume. And in fact, the air trap lung has, in fact, by contrast, increased in volume. And that's a crucial feature to be aware of when it comes to interpreting a Mosaic attenuation pattern. But again, you don't need expiratory CTs to always be confident about the diagnosis. Here is another case of a patient with rheumatoid arthritis-associated obliterative bronchiolitis, and you see a quite striking Mosaic attenuation pattern with, or at least it's more striking on my screen, I have to say, but you can see quite widespread areas of ground glass opacification and reduced attenuation lung. And the way you can determine that you're dealing with a airways-related problem is by looking at two things. First of all, the large arteries, and secondly, the large airways. There is mild bronchial wall thickening. Sometimes you also see bronchiectasis, suggesting that this Mosaic attenuation is due to small airways disease. But also, crucially, the vessels are of similar size in the black and the grey lung. And that is something that is quite different in a Mosaic attenuation pattern due to pulmonary vascular disease. In this patient with chronic thromboembolic pulmonary hypertension, you can see a very striking Mosaic attenuation pattern, but also a very large discrepancy in the size of the arteries in the ground glass areas versus the low attenuation areas. And of course, you can also look for other evidence of pulmonary vasculopathy by scrutinizing the main pulmonary artery. And the other clue here that this is pulmonary embolic in nature is, of course, the presence of hypertrophied bronchial arteries, which is a sign that you see in chronic thromboembolic pulmonary hypertension. So just a couple of other methods which can enable you to identify gas trapping on CT without resorting to expiratory CTs. It's been well documented that minimum intensity projections, or MINIPs, are able to pick up subtle low-density areas better than conventional CT, and these correspond with lobular areas of air trapping. But that can be quite cumbersome and, depending on your PACS workstation, may not be easy to do. But what is very easy to do is to simply narrow the window settings. And if you are not sure whether you're dealing with a Mosaic attenuation pattern, simply narrowing the window width to about 300 can give you a very striking image of grey lung next to black lung. And just to show you, that was the standard window settings at the same level. So such a simple maneuver can sometimes make a subtle Mosaic attenuation pattern more obvious. I mentioned earlier about the question of whether or not air trapping was clinically significant, and this is literature that you should be aware of when it comes to interpreting expiratory CT. It's been shown in a number of publications that healthy asymptomatic individuals can demonstrate air trapping on expiratory CT. In fact, up to 80% of subjects in some studies. Now, usually the air trapping, the extent of air trapping is fairly mild. No more than 5 lobules would be a typical maximum, but that doesn't include all healthy individuals. Some studies have shown that up to 25% of the lung can become air-trapped in healthy asymptomatic individuals. So can you have a particular figure in mind which says this is pathological or not? The answer is no, I think, because the clinical information is crucial. If you have a patient who has a bone marrow transplant or a lung transplant, then even a few lobules become very important. But if the patient is asymptomatic, then your threshold for calling something significant will be raised. So if I go back to this particular example I showed you earlier, the question to you is, do you think this is clinically significant? Well, certainly there are more than 5 pulmonary lobules, aren't there, that are air-trapped. There are quite possibly more than 25% of the lung is involved here. And again, the way I would interpret this is by certainly raising the possibility of significant air trapping in my report, but it's up to the clinician to assess clinically, for example, whether the patient is symptomatic and correlate with their clinical history. The problem of differentiating significant from normal physiology is also made worse by the fact that lung function parameters are neither completely sensitive nor specific. I can recommend this article here by Van den Berg for anyone who's interested that goes into this in a lot more detail, but the fact that there are at least half a dozen variables that have been described in the literature as being relatively reliable for small airways disease tells you actually that none of them actually are very good. But the clinicians in our institution tell me that they rely on the forced expiratory flow rate in the mid-expiratory cycle as being the most reliable, if you like, indicator of small airways disease when it comes to looking at lung function parameters. Okay, moving on to the second half of the talk now, which is the role of expiratory CT in the investigation of tracheomalacia. And again, just to start off with some very basic revision, the shape of the trachea, as you all know, in inspiration is round or oval, and in expiration is said to be D-shaped, and the reason for that is the fact that the posterior membrane bows a little inwards during expiration, and the reason that the rest of the trachea doesn't change shape is because of the so-called C-shaped cartilaginous rings, which maintain the shape of the anterior and lateral walls. I've always wondered why it's called C-shaped. It looks much more like an N to me, but that's why the trachea stays in the shape that it does. So what's tracheomalacia? Well, it can be regarded as a condition characterized by excessive collapse during expiration, and crucially, it's due to weakening or softening of those cartilaginous rings. And you've already heard in Dr. Svertzelati's excellent talk that it can be seen in up to about 20% of patients with COPD, but another common scenario where you might see it is in patients who've had prolonged intubations. It's speculated that the balloon cuff from the intubation process results in localized necrosis of the cartilaginous rings, causing the tracheomalacia. It's also seen in a condition called relapsing polychondritis, which is a rare condition, which I will touch on briefly at the end of the talk. So again, this is something that's already been touched upon. There is no standard method to diagnose tracheomalacia, and the figure you choose to diagnose it will depend on whether or not you want to be sensitive or specific. I would certainly recommend using a higher cutoff for the reduction in cross-sectional area before you confidently suggest the diagnosis. Otherwise, you will be over-diagnosing cases, because it has been shown, just as it has with air trapping, that there is a significant overlap between healthy individuals and pathologically diseased individuals as far as the amount of tracheal collapse is concerned. An important point technically, as has already been mentioned, is that you can best appreciate the reduction in cross-sectional area by doing a dynamic expiratory CT. And this is illustrated well, I think, in this example. This patient has You can try and guess what the cause of the tracheomalacia is here. Well, the clue lies in the upper lobe fibrosis. This is somebody who had prolonged intubation. And even on the inspiratory scan, you can get a clue that this patient has tracheomalacia. They have a so-called lunate configuration to the trachea. Then during dynamic expiration, you get near complete collapse. There's no question that that is pathological. It's nearly 100%. And then at end expiration, we have a slight opening up again. And the reason why you get that maximum reduction during a dynamic expiration is because it's during the expiratory cycle where the greatest difference between intrathoracic and intratracheal pressure exists. It's not just cross-sectional area that's important. The shape is also important, and Boisel and Ernst describe this sign, which can be helpful, the frown sign, as being a clue towards that you're dealing with tracheomalacia. And this is simply the scenario where, in expiration, you see the anterior and posterior membranes come together very closely, but the lateral parts of the trachea are maintained in position, giving rise to a so-called frown shape. So how do you distinguish cases where you're not sure whether or not the tracheomalacia is clinically significant or just normal variation? Well, just like with air trapping, again, the lung function parameters are not completely reliable. However, history can be important. It has been described that patients have a characteristic bark-like cough, and in fact, these patients tend to present more commonly with cough and recurrent infections than they do with shortness of breath. So that can be something that's useful to be aware of. What about bronchoscopy? Well, bronchoscopy can certainly confirm what you've suspected on the CT, but just as we may have difficulty in determining the extent of cross-sectional area reduction on CT, you can imagine the bronchoscopist is also going to have difficulty trying to guess how much the trachea is collapsed by. So there is also a problem there in terms of observer variability. I want to briefly mention this term, excessive dynamic airway collapse, which has been gaining popularity, it seems, in the radiological literature, or EDAC, as it's called. Let me just say at the beginning that different authors will consider this differently. Some regard this as being the same as tracheomalacia, and others regard it as a distinct entity. What it is, pathologically, it's different, is that, as I've already said, in tracheomalacia, the cartilaginous rings become softened or weakened, whereas in EDAC, the cartilage is maintained in integrity, but it's just the posterior membrane that is weakened. And it has been said to be more common than the conventional type of tracheomalacia in patients with COPD. And the other relevance for identifying it is that these patients may tend to benefit more with non-invasive ventilation to treat it rather than stenting. Personally, I think it's not crucial to make the distinction. It's more important to identify the tracheomalacia. And part of the, and I'll explain why it's difficult in a moment, but here's just an example of what you might call EDAC, very excessive posterior bulging of that posterior membrane compared to the example of tracheomalacia I showed you earlier. Now, the problem here is that what is the gold standard? No one's ever going to have a tracheal biopsy to tell you whether or not the cartilage is intact or not. And certainly on CT, when was the last time you looked at the tracheal wall cartilage? Well, it's not something I do very often, but this is what it looks like normally. In a young patient, you can barely make out the tracheal cartilage, but with age, as with many other structures that are composed of cartilage in the body, it can become more calcified. So both of these are normal appearances of the tracheal cartilage, and it's quite difficult to make an assessment of whether or not that cartilage is weakened. There is one condition where it is important to look at the tracheal wall, and that's this case here, where you have very severe thickening of the anterior and lateral aspects of the tracheal wall. And this is, of course, relapsing polychondritis. And in this condition, not only do you get tracheomalacia, you can also get tracheal narrowing or stricturing. And another crucial component to be aware of is that it causes concentric narrowing of the trachea. So in contrast to some of the shapes that I showed you earlier, which were more crescentric, this is much more concentric in nature. And it also spares the posterior membrane because, of course, that is a non-cartilaginous structure. What is relapsing polychondritis? Well, I should say that clinically it's an inflammatory disorder of multiple areas of cartilage within the body. Patients may present to clinicians with painful ears, irritation of the nasal cartilage, or it may be that it's first picked up on the CT by the radiologist with a picture such as the one that I've just shown you. So there are just a few points that I've put down here to take home. There could be many others. I think I've shown that expiratory CT can certainly be helpful for the detection of air trapping, but it isn't always necessary, and it's important to look for clues even on the inspiratory CT as far as making a diagnosis is concerned. Dynamic expiratory CT is certainly of importance when it comes to the detection of tracheomalacia, as I've illustrated, and perhaps one of the most crucial pieces of literature to be aware of is the literature in the healthy asymptomatic population, which has shown quite significant overlaps between healthy and diseased individuals for both air trapping and tracheomalacia. So before I finish, I don't have a slide, but I'd also want to plug the European Society of Thoracic Imaging meeting in Amsterdam in June later this year. But thank you very much for your attention.